Well, let's roll. So, who's excited to learn about perinatal psychopharmacology? Now, this is specifically designed for providers. The one that I did last month was like a more general audience type. So, if I start talking in provider speak that doesn't make sense to everybody, for example, I was asked to explain a little bit more what epigenetics is this time, because maybe not everybody has the background. Like, I think you can feel free to shout out or maybe type. I think it'll pop up, and if you need more clarity, just let me know. But the way that this is essentially designed is for providers. Okay, so disclosures. Nobody's paying me to do anything, but I mean, I bring up my clinic, which is Improve Life, so I own it. So I guess that could be a financial disclosure. But if I talk about referrals or different places, just know that nobody's slipping me any cash to bring up the name of their facility or anything. Okay, so we're going to talk about screening, and so PMADs we'll get into. I think everybody should probably know. And then appropriate follow-up. So you don't want to just make a diagnosis and not get follow-up. And it's important to understand who can prescribe the medications. We'll get into a little bit more of that. And then just general 1,000-foot overview guidelines of prescribing. Okay, so the first thing is, why do we care? And I don't feel like enough people do care. I feel like a lot of physicians and prescribers aren't really well educated, but I just don't understand why, because it's extraordinarily important. Look, suicide is the third leading cause of maternal death. So it's like a big deal. So that's definitely very important. And it's the depression in the perinatal period is the most underdiagnosed obstetric complication. So very important, very important. And very common, 1 in 5 women. And guess what? Even men, 1 in 10 men. And then let's say that, I don't want to be terribly cynical or anything, but let's just say the general population isn't too concerned about mom. Well, guess what? It has consequences for the child too. So everybody should theoretically, in an ideal world, care about mom, but let's face it, some people don't. So for those people, if you're trying to get your point across to them, do emphasize that it has a consequence on the baby too. So it's important for everybody. All right, so I don't want to go in too much to maternal death, but like I said in the last slide, suicide is a huge contributor to maternal death. And I just have some definitions, because I feel like pregnancy associated death and pregnancy related death, maternal death, and late maternal death, the definitions kind of get confused. So I just wanted to include the definitions here in this slide. And then also on the left, you see that there are studies, specifically in the UK, they've actually found suicide to be the #1 cause of maternal death. So depending on basically all the studies say that it's a huge contributor, but that one in particular actually names it as the #1. So of course, getting to treat this population, in case you didn't get the point across, it's really important. It is a big deal. All right, so I still see a lot of prescribers saying, oh, this is category C or this category D. That actually is no longer a thing. So they were abolished in 2015. They were really based on animal data. And I think most prescribers would be familiar with thalidomide. So that's like one of the biggest teratogenic no-no medications, because it was used for pregnant women having nausea and things like that. And then they found out there's like a very distinct direct correlation with limb abnormalities in babies where moms are on thalidomide. They were being born without arms and things like that. So that's like a very concrete, straightforward example of, and I keep throwing these words out, and I'm assuming that most people are prescribers, but just in case, teratogenic means that the medication is negatively impacting the unborn child. So thalidomide, super teratogenic. And so that's just one example. But the category A, B, C, D, and X were really not very explanatory. They found a better way, and that's actually called risk summaries and clinical considerations, and that's going to be in those large medication guides that they will give to the patient at the pharmacy. And so if you specifically get out one of those guides, another change that they made is in section 8, so 8.1, nursing mothers is now just lactation, and 8.2, the labeling section is females and males of reproductive potential, because I suppose if you're not really familiar, it could be an individual who was biologically born a female who has transitioned to being male and then became pregnant. So you want to just say like people of reproductive potential. So this slide basically shows the updates that have recently, and when I say recently, I guess 2015, occurred, because I still do see prescribers going with the old school way of things, and I just wanted to let everybody know that there's been updates. Okay. And again, if I know that everybody that is here understands how important this is, but let's say that you're speaking to, for example, I have this all the time, is that the pharmacist, a good example is a pregnant woman with asthma goes in to get her steroid, and the pharmacist looks at her and she's, which you shouldn't assume anybody's pregnant, but they do. And they say, oh, you look like you're pregnant. I'm not going to fill your steroid. And then it's like, well, I guess the mom's just not going to breathe. So if you are talking to somebody who doesn't understand just how important this is, you can inform them of these following things. So when the mom's depression or mental health needs are not addressed, that will affect the baby in a variety of negative ways. And so increased risk of child abuse and poor relationship problems, and then medical conditions get worse, and then you could have marital problems, separation, divorce. And then of course the big ones are infanticide, homicide, suicide, like huge risks. And then alcohol, drug use, problems with unemployment. So here's a list in case you have to convey to somebody that isn't understanding about how important this is. You can just refer them right to this list. Continuing on, if you are specifically speaking to maybe an OB, I've had, unfortunately, OBs that are like, no, stop your antidepressant. It's like, oh dear. So yeah, I think that there are copies of the slides somewhere, but I'm happy to give them out. Sorry, I saw a question pop up and I just answered it. Okay, so like, let's say you're talking to an OB, you can inform them that poor mental health is associated with higher risks of obstetric complications, which is going to make their job more difficult. And that includes preeclampsia, hemorrhage, premature delivery, and suicide. Like, so if you're talking to the OB, you want to emphasize that there's obstetric complications to not treating the pregnant person's mental health. And also, if their mental health is not being addressed, studies show that they're going to be less likely to attend physical health doctor appointments as well. So you can tell the OB, you know, if she gets too depressed, she's not going to want to leave the bed, which means that she's not going to be able to follow up with you during the OB visits, that sort of thing. And then, like we talked about on the last slide, there's a lot of problems with like the family dynamics, and maybe the mom's not bonding with the infant. There's going to be greater risk for physical illness if they're not going into the other type of doctors because they're too depressed to do anything. And then there's going to be emotional behavioral difficulties. So I've been going on about the importance of getting the mental health treated, specifically for the topic today, with medication. Obviously, if their mental health can be treated not with medication, you can do that. But for the sake of today's topic, I'm going to focus on treating the pregnant person's mental health with medications. So this is where I need to define the epigenetics. So when, again, I know everybody here knows it's important, but if you're trying to convince somebody else that isn't as understanding, you could explain to them also this concept of fetal programming, which is if the mom's mental health isn't addressed properly, it can actually change the expression of DNA in the baby. And I think a lot of people overlook this. So epigenetics is if you have two identical twins and their DNA is the same, they might not turn out exactly the same. You know, one could end up being like super healthy professional athlete, and the other could end up being, you know, like a couch potato. So the environmental stressors and different things in the environment can actually do something what's called, well, methylation, but for simplicity's sake, it basically can activate or deactivate different genes. And so like you can silence genes. And actually, if you're silencing genes or expressing genes, recent studies have shown that this can go generational. So let's say you have a patient and she has wildly uncontrolled bipolar disorder, and not only can that change the expression of genes in her child, but her child's child as well. Like it'll go generations. And I feel like not enough people know this. It's just very, very important for multiple family members. So this is a picture that I drew basically. So we have the sad face. If you have lots of maternal depression there, I'm not even going to say the name of this promote, but basically this area is methylated and the glucocorticoid expression goes down, which disrupts the hypothalamic pituitary axis system, which leads to increased psychiatric disorders in the child. But if you have the happy mom, then you don't have that methylation and you have less cortisol stress reactivity, happy face, and then the child will have good coping behaviors. So I hope like the happy faces lead to more happy faces and the sad faces lead to more sad faces. All right, so again, the fetal programming, this is from an epigenetic standpoint. I won't go too into this, but basically you can turn on and off genes based on environmental things that are going on. And let's see, you can downregulate or upregulate the glucocorticoid receptors. So if you have a child with fewer glucocorticoid receptors, they'd have higher cortisol levels, and then the child will be irritable and difficult to console. So suffice it to say that taking care of mom is really gonna help the baby, and mind-blowingly, the baby's baby too, like on for generations. So see, you can thank your grandmother for, well, I don't really know how generations ago they probably didn't treat, but for taking care of her mental health, because it will be passed on for generations. Okay, so I don't want to get too much into the epigenetics, but you want your infant to have a good stress reactivity, and so taking care of mom's mental health will help with that. Now, getting into, now that we know, for goodness sake, it's important, let's talk about actually switching or stopping, or what are we doing with medication. So I get a lot of calls, interestingly, from other psychiatrists. In fact, this morning I had a colleague message me. He has a pregnant woman on an antipsychotic, and he's like, what on earth do I do? Because it's not super covered in medical school, to be honest. I had to go get extra training in this. And so I get a lot of questions like, do I stop this med? Do I switch it? Do I decrease it? And the general rule here is if it's working, continue it. Now, I guess I got to do a disclaimer that this isn't medical advice, because obviously it's going to depend on the patient and all the specific factors. But very in general, if it's working, just keep it. I have some examples in a few slides of medications you might not want to, but this is just very general. Okay, so you have a woman on Paxil, she wants to become pregnant. So out of all the medications, there has been some talk about Paxil not being super great for pregnancy. You could switch, right? You could switch to something that has more safety data, more research, more commonly used, like Zoloft. But it depends on like if Paxil was the first thing she tried, you could. But if she tried other things and then they didn't work, just keep her on the Paxil. Okay, so decreasing is really not a great idea. And that's going to be because if you decrease the medication, then the baby is still exposed to the medication. And then on top of that, also potentially exposed to untreated mental illness. And so the baby's being exposed to two negative things instead of just one. So don't decrease the dose. And actually, there are some medications where not only should you not decrease, since you actually do need to increase the dose. So if y'all are prescribers, you would probably be familiar with the P450 system. So liver enzymes break down different medications. So if you have lamotrigine, there's a couple things going on that might necessitate a higher dose. For one, the fluid volume increase in the pregnant woman, and for two, the changes in the activity of the liver enzymes. So if the liver enzymes are ramping up and really metabolizing medication quickly, then the levels aren't going to get as high as they were before, and you would need to increase. And then lithium, during pregnancy, there's increased renal excretion and during the third trimester in particular. So if somebody's on lamotrigine or lithium, they should probably see somebody like me. But like if they can't get in, like it's good to know that there might need to be an increase in this time, because sometimes prescribers decrease, and that's not gonna control the symptoms. And if your liver enzymes are really burning through it, they might not even be anywhere near therapeutic levels. All right, so I said that I'm going to say some medications to not do. I think, I don't know, well, everybody's pretty much muted, but I love class participation, but I would ask, like, which one's the big no-no? And it's valproate. So if you have like Depakote, that's really associated with neural tube defects, cognitive problems, neonatal hepatotoxicity, not good stuff. So I never prescribe a person of reproductive potential valproate. I've never done that, but I've had people come to me and they're on it, and then so it is possible, but it's just, if there's something else that you could do, it's pretty teratogenic. But it's also weighing risks and benefits. So if the specific case you have, like this person's tried literally everything and valproate's the only thing that works, you may have to keep. But I've never even seen that. Like there's always an opportunity to try something less teratogenic there. And then, like I said, there have been studies about Paxil. I actually don't prescribe Paxil mainly because everybody really complains about the weight gain, and it just so for my patients, I don't have to worry about these things because I don't prescribe the Depakote or Paxil anyway. But if they did come to me from somebody else, then that's when they would. So Buspar is okay, but it's usually used as an adjunct. It's not, I've hardly ever seen it do anything just by itself. Not much information pertaining to pregnancy. So it's not like the Buspar is teratogenic. It's just like kind of isn't going to do anything by itself anyway. And then prazosin, again, you could, especially if they have horrendous PTSD nightmares, but prazosin is also a blood pressure medication. And so if you can deduce why giving somebody a blood pressure medication during pregnancy might not be a good idea, let's all take a minute to think. Because it could falsely decrease the blood pressure and then mask the symptoms of preeclampsia. And then the OB will be like, oh, your blood pressure is normal, but it's because you're on prazosin and you actually are having symptoms of preeclampsia. So it's not that the prazosin has been shown to be teratogenic, but that the prazosin can mask preeclampsia. So you can do it as long as you know, maybe add a handicap of like 20 points to the blood pressure, because it would be normally much higher. How am I doing on time?
Just about to shoot you a message to see if you can see it. We're 26 minutes in. Do you have a good amount of time? I think you're like 15
Well,
slides in, right?
I'll try to go faster, because we'll see. And then if people have a thing that I talked about that they're more interested in the end, then I can go back and go into greater detail.
Sounds good. We'll have a little bit of time for questions. And if you want to get engagement, I heard you say, usually I would ask a question. If you want to, more than welcome. I think some people
Yes.
are cameras off, but if anybody
Secret people, yeah.
you're more than welcome to grab some engagement. No problem.
Sure. All right. So we talked about Depakote, just don't do it. But the other ones that are not like top choices. But here are the first choices. So sertraline. Every OB loves sertraline. I'm telling you what. If it works, great. But sometimes it doesn't work for people. It has a low excretion into the breast milk. Lamotrigine is all right for bipolar disorder, but sometimes it's just sometimes not as effective, especially for like really serious manic episodes. Remeron can do, it's a multitask. It can help with nausea, help sleep, because when you're pregnant and you're thrown up and you can't sleep, so you take Remeron, it helps with both that and it helps with depression. So I like the Remeron. And then if you need to sleep, Unison, Benadryl, Vistaril, less than 50 milligrams. You don't want to go too wild with the visceral. So those are some good choices on this page. Okay, none of the medications we've talked about, none of the SSRIs have ever been FDA approved for the treatment of postpartum depression. And again, when I say postpartum depression, I talk about like PMH, like perinatal mental mood and anxiety disorders. I'm just using the terms in exchangeably, but brexanolone and zuranolone are now approved for postpartum depression. The brexanolone is $30,000 and it's over 60 hours infusion in the hospital. So it's not too practical for everybody to take advantage of. But the zuranolone is a pill. It actually isn't technically out yet. It should be out like this month or next month or something. But before I explain how those work, just steroids, testosterone for males, progesterone, estrogen for females. Just get our mindset into a steroid. So allopregnanolone, it's just naturally occurring. After you have a baby, it might decrease, and it functions to decrease anxiety. So if you have something that decreases anxiety decreasing, then you have obviously increased anxiety. So these two medications, brexanolone and zuranolone, actually sort of mimic that and then can take over for that drop that occurs. But the zuranolone is going to be more available because it's a pill and not an infusion, and hopefully doesn't cost 30 grand. So GABA is an inhibitory neurotransmitter. It's calming, and zuranolone is what's called a positive allosteric modulator. So it enhances the activity, and then it increases anti-anxiety effects. It's similar to a benzodiazepine, but benzodiazepines only work intrasynaptically, and zuranolone works intrasynaptically and extrasynaptically. So it's got a little bit extra mechanism of action. And so there's those two mechanisms of action, and it's going to combat the decrease of allopregnanolone that happens after giving birth. It's going to be a controlled substance, so you got to have your DEA license. And then it should be available soon. We'll see. And I really hope it's not 30 grand. And then I might skip the definitions of the stages of the clinical trials, unless at the end somebody's really excited about the stages of clinical trials, and then we can come back to this. But I just wanted to talk about some of the studies about zuranolone because it seems super promising. So this is just an example I won't go into, but they're basically finding that it's really effective and after 3 days. So most antidepressants, SSRIs, 6 to 8 weeks. I mean, this is helping in 3 days, and you only take it for 2 weeks. And so I think that's going to be exceedingly appealing to people because, a lot of the antidepressants you got to take for months or years or even the rest of your life. But this is 2 weeks. And then this is one of the studies that showed that it started working after just 3 days. Another study actually looked at just an antidepressant versus an antidepressant and zuranolone, because the question that I get is, can you take zuranolone with your standard SSRI? And the answer is yes, because they did that in one of the studies. And so it works quickly. You only have to take it for 2 weeks. So how long does it last? And so this study that was a year long showed that the fractions and decimals might be confusing, but 80% of the patients responded, so it worked for 80, and then of that 80%, they only required 1 or 2 2-week treatment. So it's not like many people had to keep going to do the 2-week treatments over and over again. So it seems to last. So it seems fast and it seems very, very good. The thing I could find is that the Sage and the other pharmaceutical companies that are selling it are also involved in the research. So take that as you will. We'll see when it starts getting prescribed, but it looks pretty promising. And then the headaches are going to be what you would have typically with the benzodiazepines too: somnolence, headache, dizziness, sedation, that sort of thing. But these things you're going to have when you're pregnant and postpartum anyway. So it's probably hard to really differentiate. And then I have an entire 40-minute long talk about zuranolone in case you guys are like, wow, I want to hear so much more. It's on my YouTube channel, which I hope everybody goes and subscribes to. So we have a case, and maybe we won't get through all the cases, but let's say that you have 30-year-old G1P0 in your office. She's 8 weeks, gestational age. She has a history of suicide attempts, overdosing 15 Tylenol back in 2018. She tried various SSRIs. They didn't work. She found relief with Viroxetine. And that's not going to be one of the most common, well-studied. So now you're nervous, right? You're like, Viroxetine, that's not super common and well-studied. But her depression has been well managed. And so her current prescriber, who is one of those people that I was referencing at the beginning that you need to explain all the importance to, read on Wikipedia that she shouldn't take it during pregnancy, and then they wouldn't give her a refill, and now she's only has 4 pills left. I mean, oh no. Okay, so the big thing, I actually don't do 90-day supplies of anything because 700,000 people overdose on medication every year, and I just don't like to give people large quantities of meds, but especially if somebody has a history of overdose. So don't give them 90 days. That's the first thing there in red. If she tried various SSRIs and they didn't work, it really doesn't make sense to switch to an SSRI, even if you're more comfortable with it, because there's so much more research. It didn't work. Don't try it again. And then the Viroxetine is working, so stick with what works. And then if her provider is looking stuff up on Wikipedia, maybe find her some referrals to somebody else. And then they didn't give them the refill. You can have withdrawals, like that's this. Find a new provider. And then just make sure that she follows up with somebody that's not one of those people that I alluded to at the beginning that doesn't understand how important maternal mental health is. Okay, so there's a lot of conflicting information. Like I said, in medical school and residency, we didn't really get too much in. I think that doctors are scared from a liability standpoint. I have an entire series on my YouTube called Pregnant Women, the Therapeutic Orphans, as to why. So prescribers feel more of a sense of connection with a negative result if it's based on an action they took. So prescribing a medication, something bad happens, as opposed to an action that they didn't take, not prescribing a medication and something bad happens. So if you're interested in more, it's on the YouTube. But so it just really makes patients not very trusting in the process if the different providers are telling them different things. Okay.
Dr. Waggel, just checking in with the time. We're at 12:36.
All
right. Like 10 minutes before we want to.
10 minutes. Okay. So one of the things that I find, I've included this slide because it's so impactful, is I have moms come in and they like are worried about going quote crazy. And crazy is not a word that I like to use, but I mean, I think we all know like what they mean. Unwanted thoughts. It's most commonly anxiety or OCD, but it's just really important to establish intent. So if they're having thoughts about harming their child, if it's ego dystonic, that means that they're bothered by it, and that's probably anxiety or OCD. But if it's ego syntonic, meaning they think, oh, that could be a good idea, then it's psychosis, and that's like a big emergency. So that's something that's very important to differentiate. And then I'm sure everybody knows the risk factors for suicide and then protective factors for suicide. Now we want to screen, and then so this is supposed to be for providers. So if any of you are pediatricians, the American Academy of Pediatrics actually wants you to screen at the child's 1 month, 2 month, 4 month, and 6 month. Now, I have 2 kids, and I don't think this has ever happened, but this is the recommendation. And then if you're an OB, you're supposed to do at least 1 screening. I feel like it should be more, but 1 screening during the perinatal period. And then these are some obvious things like give them privacy, make sure that they speak the language that the screen is in, and then make sure to look at it before they leave, because what if they leave and then they wrote on it that they're having suicidal thoughts? Like, just look at it before they go. And then these are some examples of different depression screens that you can use. This one is my favorite, the Edinburgh or Edinburgh, depending if you're from Scotland or not. Now, after you screen, you don't just say thanks, goodbye. You want to make sure that they follow up with somebody about that. So they could follow up with me, and there's a list on Postpartum Support International and Postpartum Support Virginia of certified prescribers that won't be like the people at the beginning that are like, oh, stop all your meds. Now, these are different levels of care. So outpatient's what I do. Next step up is intensive outpatient. This is if things are getting more serious. If they need medical supervision, partial hospitalization, and then hospitalization if it's like risk, like the mom that I was talking about earlier that was having thoughts of harming her child, that was something that was ego syntonic, meaning she actually doesn't think is a bad idea, and that's hospitalization. All right, so we have 23-year-old woman, sexually active, and let's see, she has psychogenic vaginismus, and then you find out she's on valproate 500. Who prescribed this to her? She hasn't had a period in 2 months. She was started on by a prescriber that wasn't like us. And then let's see, she well, it was because of a manic episode involving theft and that sort of thing. Let's see. So what are we going to do about this, basically? So first thing with the psychogenic vaginismus, let's get her a trauma therapist or a sexual medicine specialist. And I'm actually very good friends with a board certified sexual medicine specialist. So if that's ever anything you encounter, I actually know one. And then if somebody else already started her on the valproate, so the damage has been done. She's got to get on folate as soon as possible to combat the potential neural tube defects. And then if you're an OB, you're going to want to do a maternal alpha fetoprotein and ultrasound or amniocentesis to see if the valproate that she was on had an effect. And then I always see these like overdiagnoses of bipolar. So I would do a whole new evaluation to see if she actually even really does have bipolar disorder, because she might really not, and then definitely doesn't even need to be on valproic acid. And it could be just because if she's on cocaine, well, that's going to mimic manic symptoms. So I would say refer to a reproductive psychiatrist. I mean, in an ideal world, right? Like that's where she needs to get, because there's been a mess up in this case at some point. So definitely get her to the right people. Now this is a pop quiz. Opioid use. So if you have a mom who is on methadone for opioid abuse and she's pregnant, do you taper her off the methadone and discontinue the methadone because she's pregnant? Or do you maintain the methadone during the pregnancy? What do you guys think?
Maintain.
Yes, that's it. There's a common theme here, I see. And the research actually shows, like I said at the beginning, a lot of doctors are nervous and they're like, no, she shouldn't be on anything at all. Let's quit the methadone. The research shows that they're going to get back on the heroin, and it's just better to keep them on the methadone. Let's see. Do I have time for a third case?
You do, definitely.
Okay. All right. So now you have your 32-year-old G2P1 previous cesarean, 21 weeks gestation, presenting to obstetric triage. She's having abdominal pain, constipation. She's got a white count, low-grade fever. You're amazing. And so you find out it's an intestinal obstruction. You are starting to admit her to the hospital. So you're doing the med reconciliation that you do when you admit somebody to a hospital. And then she tells you that her prescriber decreased her venlafaxine from 100 to 50 because her prescriber found out she was pregnant and did not watch this presentation and decided to decrease the medication. And now she is feeling tearful and guilty and worthless and hopeless. So first things first, you're gonna do the surgery for the intestinal obstruction. You always want to check with anesthesiology. In most cases, and I actually asked a poll of my many anesthesia friends, and I haven't heard any of them say that they ask the patient to discontinue their antidepressant. So, every anesthesiologist is different, but in all the ones I've interacted with, they don't have the patient stop their antidepressant. So you could probably continue with it. And so you could continue the 50 milligrams just until the surgical emergency is over, but you would definitely want to consider going back to 100 because that is the amount that works. And then obviously you want her to have follow-up. And while she's in the hospital, I know some hospitals don't even have a psychiatrist, but if they do, you want to get the psych consult and definitely get her with a perinatal trained psych provider so that she doesn't go back to somebody that's going to decrease her medication and get her to the point where her symptoms aren't controlled. Okay, so here's a list of resources for professionals, and then here's a list for patients. And you guys should have a copy of this. So I won't read. You can just look later at the copy that you get. And then I have free group sessions on Wednesdays. This just explains the differences between a support group and a therapy group. So it's kind of a combo of both. If anybody's interested, free is a great price. I think people like free. And then on my website, I have some examples of past group discussions. Usually somebody will like bring up an issue, and then as a group we'll all talk about like potential ways to combat that issue. And then after each session, we send follow-up emails that summarizes the advice, and it includes like links to different like laws. For example, somebody said that they got yelled at for breastfeeding in a waiting room. So whenever we sent the summary email, like we included links to like Virginia state laws regarding breastfeeding and those sorts of things. So we love resources that improve life. We just have lots of lists of things and places to go, because when you're stressed out, you don't want to be doing research because that takes too much mental effort. So if somebody could just tell you, here's the laws for breastfeeding, it's much more helpful than like the new mom having to go to like LexisNexis and get on some legal sites and do research. So this is the website for the group therapy. All right, so the extraordinarily very, very generalized idea is if the psychiatric medication is helping, do not decrease it or discontinue it just because your patient becomes pregnant, in parentheses, except valproate. All right, so my office manager helped me edit this, so I'm going to shout out to her. And my audience, you guys are great. Yes, thank you to you. And then, if you could follow me on all these social medias, that'd be fantastic. Instagram, TikTok, even though I think TikTok's really toxic. Miriam handles but still, if you want to follow me, YouTube would be the best one because I got like 150 videos on various topics on there and the other ones. So please follow. And then here's some references, and then some more references, and then some more references, and then some more references. All right. Thanks, guys. References, and then some more references, and then some more references. All right. Thanks, guys.
Thank you, Dr. Waggel. That was amazing. I learn a lot from you every time I hear from you. I follow her on YouTube. I linked it in the chat if anybody else wants to follow. You were very informative, and it is an honor to watch you present. Thank you so much for all of that information. Do we have any questions? I feel like you were very informative, but any follow-up questions? Anything anybody wants to add?
I do.
Yes, please, Amy.
I was thinking that with all of these, I look like crap because I just went for a run. That's why I didn't have my camera on for a while. But I want to say, like, with all of these new restrictions on abortion in a lot of states, I would think that you've got a lot of women who have to carry an unplanned pregnancy. There's going to be great stress on them. And even if they're not clinically depressed, that would impact the baby if they don't actually want to be pregnant. So I feel like that's going to cause other problems, like increase the maternal mortality rate, just like the connection that you've made between women who are depressed and it affects the baby, and then also having higher rates of preeclampsia and hemorrhage, or I think you said hemorrhage.
Yeah, that's true. And actually, so I've recently taken to it's awkward, but usually when someone tells you I'm pregnant, you respond with congratulations. However, in my line of work, I don't feel that's always appropriate, right? Because of course I have patients that are pregnant and they don't want to be, so saying congratulations is a little insensitive. So now, and let's say if people are like, oh, I'm pregnant, I'm like, okay, well, tell me what your thoughts about that are. So regarding that, that's definitely something that is recently new. And you do have a good point, even from an epigenetic standpoint. If the mom is like really not happy and in like a really hard place, and even if she's not like DSM diagnosably definably depressed, it can still make the epigenetic changes, and then the baby might have the decreased ability to respond to stress and that sort of thing, similar to being actually diagnosed with depression. So yeah, that's a good point.
And one other question I had too was, what do you give bipolar patients if you can't give them valproic acid?
Well, okay. So the first thing is that I really truly do a thorough evaluation for bipolar disorder, because a lot of times these manic symptoms are secondary to drug use.
Okay.
And that's not bipolar. That's going to be mood disorder secondary to the use of the medication. Like if I have people on PCP, they're gonna look like they're. So first you have to truly make sure that they have bipolar disorder. I like to do lamotrigine because it has the least side effects, and you don't typically have to do levels. I mean, you can, but it's just easier and less of a side effect. You don't have to do like the supplements with the folic acid. Like it's just easier basically. Okay. But the trade-off is that it's not as effective as Depakote or lithium for true manic episodes. So if the lamotrigine works, that's fantastic, because that'll be all right. But then if it doesn't, then lithium. But I've never had neither one of those work. And then, you could always just add a little bit of an antipsychotic, which they're not teratogenic. I mean, maybe there's some questionability about Abilify, but definitely super teratogenic is Depakote. And I've never had a situation where nothing else worked and I had to go to Depakote.
Okay, thanks.
You're welcome.
Miss Laura Gayton put a few questions, and they kind of all go together a little bit. And I don't know how many you'll be able to speak to, but she said, can you speak to the big bucket that is diagnosis in postpartum depression? In your opinion, how should providers use the diagnosis? What other diagnoses are often appropriate or appropriate? I think she might mean appropriate or inappropriate instead of, in some cases. Is zuranolone, etc., appropriate for people having exacerbations of pre-existing depression or pre-existing anxiety in the postpartum period? And what percentage of people do you think this will be appropriate for? I don't know how many to those you can speak.
Well, let's see if I can remember them all.
I'll go through them again if you want. It's yeah. At first I was like, oh, these kind of go together, and I might need to break them up. So the first one was, can you speak to the big bucket that is diagnosis postpartum depression?
Yes, let's break that apart. So this is good because I wanted to differentiate. So postpartum depression, I like to use PMADs because it's perinatal mood and anxiety disorder. So postpartum depression is just depression and just postpartum, but perinatal encompasses from conception to 1 year after delivery. And then mood and anxiety disorders, you could get the PTSD in there and anxiety in there, and it encompasses a greater time frame, and it encompasses wider range of symptoms. So the reason that I will say postpartum depression is because that's what most people are familiar with, and that is the terminology that the FDA used for their approval of the zuranolone. And so postpartum depression is just more of a mainstream, more like known, but I really do like to use PMADs because it encompasses a greater time frame and like OCD and other mental health issues other than just depression. So does that answer that one? The bucket?
Hopefully.
Yeah, a little bit. I also just wondered, like, when we're diagnosing people, a lot of our patients present with anxiety forward symptoms that are coming, and there is not a postpartum anxiety diagnosis. So it's an interesting thing. So I wondered if you could. And then also I've noticed too that we've had patients come back to us and be like, you diagnosed me with postpartum depression when my symptoms are primarily anxiety symptoms, and now I can't get life insurance. And so
oh my God.
it's an interesting world out there. So I just wondered, yeah, we rely on the EPDS to help us diagnose, but we also, of course, then are assessing people. When do you, put down anxiety versus when do you put down postpartum depression? And then also, how do you deal with the fact that a lot of the times it's related to previous depression or previous anxiety? So I guess I'm asking about diagnostic codes and what's most appropriate and what you use.
Well, that's interesting because I obviously in my notes put a diagnosis, but I don't work with insurance companies, so they don't go anywhere. So that it actually says on my website, one of the reasons is because like if I report something and then they can't get life insurance, right? But it's the diagnostic codes are a tricky one. I usually just put like F33.1, like just major depression, or because honestly, a lot of them do have depression beforehand, and it's just enhanced by pregnancy. But I suppose I would like put postpartum depression for if like they didn't have any in the first place. But generalized anxiety disorder, F41.1 I would use. But I think that's more of like a billing kind of thing, which I really don't get into. Which yeah, that is a confusing, if you're doing the codes. I don't know if you guys use the DSM codes or ICD-10 or
ICD-10, yeah.
Okay. So yeah, I don't.
Yeah, I take insurance, so I usually just use adjustment disorder with anxiety or depression in combo.
And they're
I think that's
adjusting
the
the
minimal
baby.
that
I like that.
It's the minimal they'll and it's definitely an adjustment. It's a big life transition and things going on. Yeah, so it's legit. Yeah.
I think that's a great strategy, and also it keeps them out of that diagnosis that might inhibit their life insurance. And since I'm a general practitioner, I don't want to put someone in a bucket that someone else might believe is different when they get more assessment. So yeah, that's a great idea. Thanks.
Yeah, I like that. The adjustment. Yeah, that's good. Thanks for answering my question. I was
gonna say Miriam answered the second part of that. Second and the third part.
Thanks, Miriam.
I love it. Okay. Laura, did that get I know she answered your how should providers use the diagnosis and what other diagnoses are often appropriate. You still you had questions about zuranolone,
Yeah, just still curious about, is zuranolone something that you'd prescribe to someone who is having an exacerbation of pre-existing depression in the postpartum period?
So I haven't been able to prescribe it yet because it's not out yet, but I would. So in one of the studies that I spoke about earlier, they had people who were already on antidepressants, which would imply that they had depression before becoming pregnant. And so, yeah, you could definitely use zuranolone for somebody that had an underlying depression and then it was worse in the postpartum period, because that's what a lot of the people in the studies actually had a similar situation. Did that
excellent? Thank you so much. Sorry, the unmuting is just like the longest process.
Right.
I appreciate all of you. Thanks. And Miriam, what is your job? Where are you working? Sorry, I just wanted to ask.
Yeah, I'm in Falls Church City. I have a private practice, but I've been on the referral list for Postpartum Support Virginia for a bunch of years now. And then I'm just recently on their board this past year. So it's definitely one of my niches and a special place in my heart for those struggling with this in particular with the PMH-C. Yeah. So,
awesome.
Yeah.
Thank you.
Thank you, everybody. All right. And then Saba has another question. I think we have time for really just one more question. I know everybody has to go back to what they're doing. Are there any additional trainings or conferences that you recommend? There is barely any education about this specialty in the PMH-P program.
So there's one, and it's in DC area. I think it's in Alexandria. I can send it to Miss Kayla if she wants, and then she could send it to everybody, because I guess I don't have everybody's emails. And I really wanted to go because it's local and it's about perinatal mental health, but it's in 2 weeks, which is also when I'm running the Marine Corps Marathon, so I can't go. But you guys can go, and then you could tell me how it was. So I will like send the sign, because I think that you could still sign up. I don't think that there's like any cutoff, so I'll send that.
Awesome. I'll definitely craft an email so everybody has the follow-up links for that. And somebody else asked, are you going to be sharing the slides? I know we're sharing the recording, but do you want to share the slides as well?
Yeah, sure. Yeah, I sent them in, so I can send them again. Yeah, happy to share my slides.
Absolutely. Okay, and we'll make sure everybody gets connected that way. I love it. Well, thank you everybody for joining. We also have some upcoming events with PSVA. I think everybody for the most part here is already a provider that is PMH-C trained, but we are having our upcoming Understanding PMADS training again next month. And then we're also having the sharing of the screen. I don't want anybody who has to go to feel like they have to stay, so please feel free to hop up. Don't let me take up too much of your work time. Oh, goodness, this is not working for me. I'll send it in the follow-up email. But we have our upcoming Understanding PMADS training tomorrow and next Friday, going over just a little bit more in depth for, oh, goodness. And now I lost you all. I'm so sorry. Okay, so it's our 14-hour training designated for mental health professionals and anybody who is interested in learning and expanding their knowledge for accessing, for assessing and for treating perinatal mood and anxiety disorders. And then alongside that, we also have our upcoming Shalane's Run. If you all are familiar with PSVA, you are familiar with Shalane's Run. It goes directly into our Shalane's Fund that we use to give microgrants out to people and families in the community so that they can access really important care, whether it be a mental health professional, doula support, in-home support, or help financially with housing, formula, diapers, that kind of thing. So we have that coming next week. Again, or this week actually, it starts on the 19th and we go all the way to the 29th. So if you're interested in participating in that run, everybody's going to be doing it virtual, so you can run where you are and participate in whatever way you want it to be. And then we're also having some family fun days coming up. I know Dr. Waggel is going to be coming to one virtually, you said?
So, Miriam, my office manager, is going to the one in, did you see Woodbridge? The one that's south of DC. And then depending on how my children are behaving that day, I may also join, but I'm going to run virtually because I'm running anyway because I'm training for the marathon. And so I'm going to run virtually, and I may be there in person, but Miriam and some of my interns are definitely going to be there.
Yes. There's going to be a lot of games. It's going to be a real family fun day. There'll be food. There's one in Roanoke. And like you said, the Prince William County area in Woodbridge, I believe. Again, I'll send the flyers if anybody else wants to come. There'll be face painting, music, speakers. It'll be kind of like our previous Shalane's runs. But again, our Shalane run is virtual. So we're trying to still have little community get together. So feel free to join. But thank you everyone for coming. And if we don't have any other questions or anything else that Dr. Waggel wants to add, y'all have a great rest of your day.
Thanks for being a great audience.
Thank you, Dr.
Thank
Waggel.
you for the good luck. Yeah, I hope I have good weather. Yeah.
Yes, definitely. All right.
Bye.
All right, thank
Bye,
you.
everybody.
Bye-bye.
Thank you.
Thank you.